Welcome, everyone, to our discussion on the fascinating field of pharmacology. Today, we will delve into the intricate relationship between chemical substances, or drugs, and living organisms, specifically humans. Pharmacology, a branch of medicine, consists of two critical components, pharmacodynamics and pharmacokinetics. The term pharmaco means drugs, dynamics refers to the dynamics or mechanisms of action, and kinetics relates to the movement or processes involved. Together, these two elements form the foundation of our understanding of how drugs interact with the human body. Let's begin with pharmacodynamics, the study of drug action at the biochemical or physiological level. This branch investigates the mechanisms by which drugs exert their effects on living systems, shedding light on their modes of action. Pharmacodynamics encompasses two main categories of drug interactions. First, there are drugs that change the environment of cells, altering their chemical composition or physical properties. Second, and more commonly, there are drugs that selectively bind to receptors on cell membranes, subsequently altering cellular physiology. One notable example of a drug-receptor interaction is digoxin, also known as digitalis. This drug binds to specific receptors, producing its physiological effects. To better understand the concept of drug-receptor interactions, let's define two important terms, agonist and antagonist. An agonist is a drug that binds to a specific receptor and produces a physiological effect by stimulating the receptor. For instance, norepinephrine, or NE, stimulates beta-1 receptors on the sinoatrial SA node, leading to an increase in heart rate and blood pressure. In this case, norepinephrine acts as an agonist. On the other hand, an antagonist is a drug that binds to a specific receptor and blocks other substances from stimulating that receptor. Propranolol, also known as Indol, is an example of an antagonist. It blocks beta-1 receptors on the SA node, resulting in a decrease in heart rate and blood pressure. Another example of an antagonist is naloxone, or Narcan. Naloxone blocks mu-opioid receptors in the respiratory center of the medulla oblongata, reversing respiratory depression caused by opioid overdose from substances like heroin, morphine, and other narcotics. Recently, a new classification has emerged, the inverse agonist. Diphenhydramine, commonly known as Benadryl, is an inverse agonist. It binds to histamine receptors and induces a conformational change in the receptor, preventing histamine from binding to its H1 receptor. This action helps prevent allergic reactions and symptoms. When discussing receptor binding characteristics, we consider two important factors, affinity and efficacy. Affinity refers to a drug's ability to bind to its receptor. Agonists generally have higher affinity, while antagonists have lower affinity. Efficacy, on the other hand, refers to a drug's ability to stimulate its receptor. Agonists have higher efficacy, while antagonists have no efficacy. The concept of competitive inhibition is crucial in understanding drug-receptor interactions. In this process, an agonist and an antagonist compete for binding to the same receptor. For example, morphine, an agonist, competes with naloxone, an antagonist, for binding to the mu-opioid receptor. Similarly, diazepam, an agonist, competes with flumazenil, an antagonist, for binding to the benzodiazepine, GABA, receptor. Acetylcholine, an agonist, competes with atropine, an antagonist, for binding to the cholinergic, muscarinic, receptor. Now, let's shift our focus to pharmacokinetics, which consists of four phases: drug absorption, distribution, metabolism, and elimination. The absorption phase is the process by which a drug enters the body's circulatory system. One common route of administration is oral, where the drug is ingested and absorbed from the stomach and intestine, entering the hepatic portal system, then the liver, and finally the general circulation. While the oral route is convenient and economical, it's important to note that once a drug is absorbed into the bloodstream, it enters the liver, where it may undergo the first-pass effect, a process of partial metabolism before reaching the systemic circulation. Another route of administration is sublingual, where the drug is dissolved and absorbed under the tongue. An example of a sublingual medication is nitroglycerin, commonly used for the treatment of angina pectoris. The transdermal route involves the administration of drugs through the skin via a patch. This method provides continuous drug dosing and avoids the first-pass effect through the liver, as the drug enters the general circulation before passing through the liver. However, local skin irritation may occur with this route of administration. Examples of transdermal drug delivery systems include the nicotine patch, used for smoking cessation, and the diurogesic fentanyl patch, which is used for chronic pain management. Another example of a transdermal drug delivery system is the androderm testosterone patch, used for testosterone replacement therapy. The rectal route is an alternative method of drug administration, often used in unconscious or vomiting patients. An example is acetaminophen, or Tylenol, suppositories. However, it's important to note that the rectal route may result in incomplete or erratic drug absorption. The inhalational route involves inhaling a drug as a gas or aerosol into the lungs. This method can either exert a localized effect on the lungs, such as bronchodilation, or allow the drug to enter the bloodstream through the lungs, producing a rapid onset of action since it enters the general circulation shortly after being inhaled. The intranasal route is another method of drug administration, where the drug is absorbed through the nasal mucosa. The parenteral route, which includes intravenous, intramuscular, IM, and subcutaneous, SC, administration, is a direct method of introducing drugs into the body. The parenteral route offers several advantages, including a more predictable drug response, with the order of potency being 4, then IM, and finally SC. It also avoids the unpredictable absorption processes of the gastrointestinal tract and is useful in unconscious or uncooperative patients. However, the parenteral route also has disadvantages, such as the need for sterile conditions to prevent infections, higher costs compared to other routes, and the inability to retrieve the drug once injected. Additionally, there may be pain at the injection site. Moving on to drug distribution, the general rule is that small and highly lipophilic, or fat-soluble, drug molecules penetrate cell membranes, capillaries, and physiological barriers like the placenta and blood-brain barrier more readily than larger, polar, or non-lipophilic drug molecules. When it comes to drug absorption through the gastrointestinal, GI, tract, there are two important characteristics to consider. First, drugs must be relatively lipid-soluble to pass through the membranes of the GI tract. Second, drugs can exist in either a lipid-soluble or non-lipid-soluble form, depending on their pH environment. It's important to note that the pH environment changes along the GI tract, with the stomach being highly acidic, and the small intestine being slightly alkaline. These pH changes can influence the solubility and absorption of drugs. The concept of bioavailability describes the proportion of an administered drug that is available to produce a pharmacologic response. Factors influencing bioavailability include drug dissolution and the presence of inert ingredients such as binders, disintegrants, lubricants, and buffers. Regarding the GI tract, the presence of food may affect the dissolution and absorption of drugs. For example, tetracycline, or TCN, can bind to calcium in dairy products, leading to decreased absorption and excretion of unabsorbed TCN in the feces. Additionally, conditions like achlorhydria, which is a deficiency in stomach acid production, and deficiencies in pancreatic and intestinal secretions can prevent the dissolution of enteric-coated tablets, impacting drug absorption. The degree of drug distribution depends on the physical and chemical properties of the drug and its ability to penetrate cell membranes, capillaries, and physiological barriers such as the blood-brain barrier and the placenta. The blood-brain barrier, BBB, is a crucial consideration in drug distribution. Only lipid-soluble drugs and very small molecules are capable of crossing the BBB to exert an effect on the brain. This is an important factor when treating neurological conditions or disorders affecting the central nervous system. For example, heroin crosses the blood-brain barrier more readily than morphine due to its greater lipid solubility factor. This difference in penetration contributes to the potent effects of heroin compared to morphine. Another important factor in drug distribution is plasma protein binding. Many drugs bind reversibly to plasma proteins, such as albumin, in the bloodstream. However, only the unbound or free drug can diffuse through capillary walls, produce a pharmacological effect, be metabolized, or be excreted. The equilibrium between the free drug and the protein-bound drug acts as a circulating drug reservoir, prolonging the action of the drug in the body. This binding process helps maintain a consistent level of the active drug in the bloodstream. Plasma protein binding can also lead to drug-drug interactions. For instance, aspirin, ASA, can displace warfarin from its albumin binding site, increasing the level of free warfarin in the bloodstream. This increase in unbound warfarin can heighten the risk of bleeding, as warfarin is an anticoagulant, and aspirin is an antiplatelet drug. Another aspect of drug distribution is tissue trapping, where certain tissues, such as adipose tissue, are capable of temporarily or permanently trapping or storing drugs, converting them into an inactive form. When the drugs leave these tissue binding sites, they can become active again. Now, let's discuss drug biotransformation, also known as drug metabolism. The liver is the major organ responsible for metabolizing drugs, converting lipid-soluble drugs into water-soluble forms that can be excreted by the kidneys. The first-pass effect of the liver is a crucial concept in drug metabolism. This process inactivates potentially harmful chemicals and drugs before they are distributed throughout the body via the general circulation, providing a protective mechanism. The induction or inhibition of drug metabolism by the liver can lead to drug-drug interactions. For example, nicotine can induce the metabolism of theophylline, leading to lower theophylline blood levels and potentially exacerbating wheezing in asthmatic patients. Conversely, cimetidine, Tagamet, can inhibit the metabolism of theophylline, resulting in higher theophylline blood levels and an increased risk of toxicity. Drug elimination is the final phase of pharmacokinetics, primarily involving the kidneys. It's important to note that kidney function tends to decrease by approximately 10% per decade after the age of 20, which can impact drug elimination rates in older individuals. In addition to renal elimination, drugs can also be eliminated through the feces. This can occur in two ways: metabolized drugs can be excreted in the bile and eliminated through the feces, or a process called enterohepatic recirculation can occur. In this process, the metabolized drug is secreted in the bile, enters the small intestine, is reabsorbed, returns to the liver, and is then secreted again in the bile. It's essential to consider age-related factors in drug metabolism and elimination. Infants have an underdeveloped ability to metabolize and excrete drugs, while the elderly often experience impaired drug metabolism and excretion capabilities. These age-related differences can impact drug dosing and potential side effects. Furthermore, liver and kidney diseases can also affect drug elimination rates. Impaired liver or kidney function can reduce the body's ability to metabolize and excrete drugs, potentially leading to prolonged and toxic drug effects. In summary, we have covered the two fundamental components of pharmacology, pharmacodynamics and pharmacokinetics. Pharmacodynamics explores the mechanisms of drug action at the biochemical and physiological levels, including drug-receptor interactions and the concepts of agonists, antagonists, and inverse agonists. Pharmacokinetics, on the other hand, focuses on the processes of drug absorption, distribution, metabolism, and elimination within the body. We discussed various routes of administration, factors affecting bioavailability and distribution, the role of the liver in drug metabolism, and the importance of kidney function in drug elimination. Understanding these principles is crucial for optimizing drug therapy, minimizing adverse effects, and ensuring the safe and effective use of medications in clinical practice.